Hey guys, so welcome to part 2 on the vasopressor video, sorry. So we stopped last time. If you have not watched part 1, please watch part 1 and come on over to part 2. So we stopped at epinephrine. So let's talk about epinephrine, right? That is a vasopressor. Epinephrine is going to stimulate 3 receptors, right? So in the first video, I didn't even bring out this third receptor because I just didn't want to confuse you. I wanted to focus on these two, alpha 1 and beta 1 receptors, okay? So refresh your memory, right? With norepinephrine, which receptors they bind to, that kind of tells you what's expected to happen and what you expect to see. So with epinephrine, right here, epi. So with epinephrine, it's going to bind to alpha 1 receptors, beta 1 receptors, and beta 2 receptors, okay? So remember we talked about if it binds to alpha 1 receptor, what is it going to do? Yes, it's going to vasoconstrict, right? So it's going to cause vasoconstriction and therefore lead to your blood pressure increasing or the patient's blood pressure increasing, right? If it activates beta 1 receptors, which are found in heart muscle, it's going to therefore cause increased contractility. Your heart is going to start pumping better, and therefore your heart rate is going to go up, right? So with that pumping better, heart rate going up, it's going to increase the cardiac workload. Your heart muscle is going to work harder, right? The other receptor that epinephrine works on, the other receptor that epinephrine works on is your beta 2 receptors. So with beta 2 receptor, specifically backtrack. Beta 2 receptors are found in your lungs, right? So it's found in your lungs, okay? Specifically in your respiratory tracts in your lungs, right? So you got your trachea, your bronchioles, all that good stuff. So beta 2 receptors are there. So beta 2 receptors, when they are activated, it is going to lead to bronchodilation. Okay, dilation, meaning it's going to open up, or your bronchioles, open up your airway, right? So the patient's going to be able to breathe better, right? So that is one thing to keep in mind, okay, with all of this, with epinephrine specifically. That's why we use epi for anaphylaxis. If someone's having like a severe allergic reaction, of course, we ask, where's that epi? Because we want to keep that airway open and patent. Okay, but at the same time, be mindful that epi can cause blood pressure to increase, causes heart rate to increase, and increases contractility of the heart muscle. Okay, are we good? So the next one, and typically with epi, we don't start that on everybody, right? Epi is if a patient's in cardiac arrest or has like profound shock or is an anaphylaxis, like I mentioned. Okay, the next one we're going to talk about is dopamine. So your dopamine, right? So dopamine stimulates 2 receptors. So dopamine is going to stimulate your beta 1 receptor as well as your alpha 1 receptors. I almost got you there. You thought I was going to say beta 2. Nope. Dopamine stimulates your alpha 1, and then your beta 1 receptors. Okay? It raises, so with dopamine, of course, I feel like I'm repeating myself. If it stimulates A1 and B1, I'm just going to let you answer. What are you expecting to happen? Okay, therefore, so if we're stimulating A1 and B1, what's a good patient to use this for? If a patient is, of course, hypotensive, right, and they have I can't talk today. What's going on? If they are bradycardic, meaning their heart rate is below that 70 that you want. So the heart rate is, severely below. So I wouldn't just, if their heart, because there's some people that can hang out in the heart rate of like 55 or 50. So if their heart rate is bradycardic, right, and they are symptomatic, okay, and if the patient is also hypotensive, be mindful with, I don't see a lot of doctors actually using dopamine. I don't really see them using dopamine. I see them more gearing towards norepinephrine. But it's good to know what dopamine does. Okay? Dopamine, a lot of the reasons why sometimes they avoid it too, it can cause arrhythmias. So dopamine can actually lead to arrhythmias. So a lot of times doctors will avoid that as well. Let's talk about the next one, vasopressin. Vasopressin does not stimulate alpha or beta receptors. Vasopressin is special, okay? That is probably the only one that is super special. So vasopressin is going to stimulate what we call V1 receptors. Okay? So vasopressin stimulates V1 receptors, which causes blood vessel to constrict. Okay, that's the only one that's different. Okay, I'm not really going to dive into V1 receptors. I don't want to confuse you or go down a rabbit hole somewhere else. But just know vasopressin is the only outlier. You'll rarely see them out. I've never seen them ask for vasopressin. But tell me in the comment section if you guys have ever used it in the cath lab. I've never actually had them, ordered or asked for it. Okay, especially when we have those other lovely options as levo and phenylephrine as well. So let's talk about the last but not least, dobutamine. I keep saying this, dobutamine. There you go. Dobutamine, dobutamine is the only one. It's not necessarily a vasopressor. I put it there, but it is an inotrope, right? So what that means, so dobutamine is going to stimulate this beta 1 cell, so beta 1 receptors, right? So therefore, if it stimulates beta 1 receptors, it's going to increase contractility. That's why it's called an inotrope. Any medication that is going to cause the increase in contractility of the heart is an inotropic medication. So that is another outlier there. So dobutamine, you have inotrope. Okay? It's an inotrope medication. The main focus of dobutamine is stimulates beta 1 receptors. So because it stimulates beta 1 receptors, you are going to have what? The heart is going to pump more effectively, right? And it's also going to help to increase the heart rate just because of that, and increases cardiac output as well. So dobutamine does have beta 2 effects, okay? I paused and quickly kind of added that on there as well because I was going to talk about it, but I figured it's just best for you to see it as well. So dobutamine does have beta 2 effects. So it's not significant, but it does. Beta 2 receptors, not just found in the lungs, but it's also found in blood vessels, specifically blood vessels that supply your skeletal muscles and also your coronary arteries. Okay, so with that, it is going to cause vasodilation. Okay, so you see what's going on there. So dobutamine is not really necessarily our first line, right? Dobutamine is not going to be our first line to increase. I don't even think it's going to be a second or third line to increase the blood pressure. Okay, dobutamine, our goal is dobutamine is typically initiated if we're trying to increase the heart's contractility. Let's say the heart's not pumping, the heart's kind of giving out. We can start dobutamine to see if that helps to help the heart contract. Okay, so we want that heart to contract in order to push blood out so that the tissues of your brain, different organs can get oxygenated blood in order to live. Okay, so with that said, this is vasopressors and inotropes at a nutshell. Okay, let me know if you have any questions. If I missed anything, please add in the comment section. This was just a quick video, quick in and out. Yeah, thank you guys for watching. Take care. Bye.